We have so many clients who come to us with imaging. I said, my imaging shows that I have a disc herniation, I have a disc bulge. Recommendations are being made to me about I should have surgery or whatever the case may be. What's your thoughts on imaging? What qualifies someone for surgery? I know it's a lot of issues here, but they all sort of go together. What are your thoughts on that?
My advice for most clients and patients is to ignore the imaging. We have athletes who have been given the same diagnosis by imaging who are now playing in the NHL, the UFC, the NFL, etc., etc. So it's much more important for the trainer to consider the results of the assessment, to understand their pain triggers, organize the programming in terms of motions, postures, and loads that avoid those pain triggers, allow the pain to wind down, and then, as we've said many times, build them back up again to have this pain-free foundation for movement. So that should be the first in the decision tree. So ignore the diagnosis by imaging. Go with the diagnosis by offensive in terms of pain, motions, postures, and loads.
And I've heard you sometimes speak of the concept of virtual surgery, and I thought it was a really interesting way of approaching things. Can you sort of touch on and go deeper into that concept of a virtual surgery?
Yeah, this is where, once again, we really integrate the trainer into the whole spectrum of rehabilitation. I have an entire chapter on this in Back Mechanic. The idea is surgery quite often works for a patient because it's forced rest. Consider that type A client that you get and they say, you know, I'll go crazy if I don't do my half an hour of aerobics on the elliptical trainer. And they never give themselves or their sensitized tissues a rest. So we play the game of virtual surgery. I make it very dramatic. I'll take a dowel or a stick, I touch them on the shoulder and say, there, I've now performed surgery on you. Would you go back if you had real surgery today and do the half-hour elliptical tomorrow? And the answer is no, you wouldn't. You would behave like a post-surgical patient. So you pretend that you had surgery today, and now you organize a program of building up very low-level, pain-free, pristine movement habits. And then you start to add load and motions to build that pain-free life capacity that we keep talking about. I can also prove that this is very effective. We follow up with every patient that we've ever seen at the university. Of all of those who've been told, your last option now is surgery. You've failed physical therapy, you've failed with your trainer, you've failed with the psychologist, you've failed the work hardening program. We get 95% of them to avoid surgery. So I can stand by that figure and prove that this approach works.
Is there a time within the scope of practice of a trainer where you would say, well, if you can't find a ... I would say that maybe surgery is an option that you should reconsider?
Absolutely, there is. So the trainer has now gone through the exercise of performing virtual surgery and building that beautiful, pristine movement program. If after that the patient fails to find a posture that is pain-free, we have something worthwhile now of further investigation. I should also repeat once again that can be considered a red flag. If the client fails to find a pain-free position, there may be a non-mechanical, more sinister reason. And once again, if you can't find that, send them back. And make sure you inform their family doc, this isn't mechanical. There is something other in the pathway, and we've found tumors and some of the more nasty things simply by following that principle. And the trainer was key infinite because the person passed all the biochemical tests and markers for cancer and some of these other things.